Thank you, esteemed panelists and chair. Requesting you all to kindly come to the center of the stage for a picture. Thank you. So, thank you, delegates. With this, we come to the closure of session 1. We will be taking a 5-minute tea coffee break, and after that, we'll be back for a very interesting session on doctors, clinics, and hospitals. Thank you. Session 2, requesting our chair, Mr. Amit Kumar Mishra, Board and Member Secretary, HIMSS India Asia Pacific, to kindly take to the dais. Requesting our panelists, Mr. Uday Kumar, Chairman and CEO, OHM Healthcare Incorporation, OA, USA, Mr. Shirish Kulkarni, CEO, Palash, Mr. Premanshu Singh, Head of Marketing Enterprises, Practo, Mr. Vikram Anand, Founder, Health Research, Reach, Mr. Vamsi Chandra, Kasivajala, CEO, Enlytics, Dr. S.B. Gogia, President, EPAMI, Mr. Anand Ambekar, Principal Product Manager, India COE, Innovation at EMC, Mr. Sumer Sethi, MD Radiologist and CEO at Telerad Providers. Thank you. Requesting Chair Mr. Amit Mishra to take over kindly.
Very good morning, and the eminent panelist. This is one of the very, very important session which talks about clinics, hospitals, and physicians. And this is going to be a very, very interesting session. Before I go ahead with the introduction of the eminent panelist, I'll just set a perspective. Indian healthcare is kind of poised for growth, and it is going to be growing, ever growing. Due to several reasons, there are some epidemiological transition, demographic transition, there would be increase in life expectancy, lifestyle diseases. Can IT make a change? Can IT, kind of help us live independently longer? Can IT help us, kind of alleviate the pains of the patients? So we'd be discussing, and some of the, I'll ask very, very basic question. We can get, cab in 10 minutes. Why can't we get 10 minutes in ambulance, We can actually order online shaving blade, but why can't we order medicine online? These are some of the very basic questions which we're dealing in, and how we can change the shape of healthcare IT in India with the use of IT. So I'll just turn it over to our eminent panelists for their introduction.
My name is Dr. Sumer Sethi. I'm a radiologist, and I run a teleradiology firm in India. Thank you.
Hi, I'm Vikram Anand. I am a founder and CEO of Global Health Reach.
Hi, I'm Shirish Kulkarni. I'm representing Palash as CEO of Palash.
Hi, I'm Premanshu. I represent Practo. I'm the head of marketing. Yeah.
Hi, I'm Anand Ambekar. I'm product manager with EMC Square.
Hi, I'm Vamsi. I'm the president of HIMSS India. I also am the CEO of a company called Enlightex.
Hello everyone again. My name is Uday Kumar. I'm the CEO of OHM Healthcare.
I'm Dr. S.P. Gokia. I'm President of Asia Pacific Association for Medical Informatics and also President of Society for Admission of Telemedicine Healthcare Informatics.
Hello, I would request Mr. Uday Kumar, Chairman of OHM Healthcare, to start with this session. He talked about the EMR adoption, what are some of the lessons learned from the US.
Good morning, and thank you for the second session that we're going to have today on what we're going to talk about. Is this not working? Can you find the document? Yeah, this one. Oh, thank you. While he's doing this, I think we need to talk about adoption in two parts. One is technology. Why is it so hard for healthcare to have adoption issues? And the second is change management. What does it take to change from one application to another application? So let's start with what we talked about yesterday. Healthcare is complex, and at every stage of these interactions in these various phenomena that we just see from the patient side, from the provider side, and from the payer side, every transaction is very complex, and they all interact with each other. So this is the data for adoption across multiple countries. And this is a 2012 report, so it's a little bit changed today. But if you look at it, that you see Norway, which is one of the highest adoptions in the world, 98%, same as Netherlands, but what they've done is essentially adopted a basic system. So the system with multifunctional capability, that's still very low. On the other hand, countries like UK, Australia, and New Zealand have adopted a more full functional EMR, which includes data that is transformative. In the United States, for the last 4 years, we've had this program called Meaningful Use. And what the Meaningful Use program has done is it has defined specifically what kind of services have to work. For example, you need to have an electronic health record that's secure. You need to do medication reconciliation. You need to essentially record smoking status, allergies, specifically CPOE, that is doctors need to place orders for medication on the system. You need to have clinical summaries coming from the system. So there's a specific definition, and those definitions have to be achieved. And what we're really saying in the circles is how they were to be achieved year after year. As a result of this huge incentive program, the United States today can report 100% doctors using the system to place orders. 100%. That's in the hospitals. In the clinics, it's closer to 59%. But this is an achievement achieved partly because they defined what should be there, and every technology vendor had to deliver that, and also by the incentive program that says the government would actually contribute to making sure that this money is paid for. So what makes adoption so difficult? What makes adoption difficult is that this is the way EMRs work. It's very easy to build, and somewhere down the line it gets a little complicated. And those complications add up in a dramatic manner to this kind of screens. And these screens, I mean, you really cannot tell what's happening out here. And that essentially, that complication of the system and the screen design makes 90% of all the doctors look around and say, this is not meant for me. It's tough on the physicians, it's tougher on the patients. And what really happens is that nobody has time to enter detailed patient histories, nobody has time to read them. So what will happen is that EHR becomes a kind of a tool that stays like a graveyard of all the documentation that nobody wants to read. What adds to the confusion is errors in the EMR itself. And now if you look at any other staff that's also doing the care coordination, they're not clear how to go about doing this. So that's the adoption problem. So what makes it easy? Well, there are two things that we need to worry about. On the first side is the requirement. What we have is a very complex interaction of various players, and what we need is a patient-centric approach, that everyone can see the same data in the same manner, and then everyone can contribute. And that's the before and after story. And for you to achieve this, you need 4 fundamental drivers. One, that information needs to be available at the point of care, the patient history and the clinical record. The second, it has to be extremely user-friendly. It has to be usable by doctors without having to learn, 0 training required. Third, it has to be adaptable. No 2 doctors think alike, no 2 patients are alike, no 2 diseases are alike. And finally, it has to be scalable. It has to grow from a single doctor to millions of doctors, and it is known for a fact that a single patient in a hospital has between 40 to 50 people who essentially deal with the person. And all of them need to know the same thing about the patient. So these are the things that makes it the requirement. Now what we need to try to talk about here, and this is the concept that we at OHAM have tried to do, is address these issues. And the first thing we have come up with is that the doctors need to see just one screen. The entire information should be available on a single screen. And if you can achieve that, then it becomes easy. The second, all orders need to be placed by touch only. No typing, no writing oral orders. By touch alone, I should be able to place extremely complex orders. Third, I should have order sets which look like my paper sets, so I can actually place orders the way a paper order is. Fourth, all documentation required should also be touch. There is no need at this point of time in our modern world, when we're talking about Digital Health India, that we don't use digital health tools. And when I can do this level of documentation using only touch, I can essentially produce my discharge summaries and my prescription notes and my progress notes all using touch. If we do this, and this is the survey we did about a year ago with the University of Michigan, done studies of hospitals in New York and hospitals in Delhi and Pune. And we asked doctors in both these countries, what will make you want to adopt? And if you look at this system, other than the 2 things that we point out in this highlighted, which is documenting physical exams and writing prescriptions, doctors in India are actually more likely to use an EMR than doctors in the United States. The second thing is benefits. Throughout the system, we believe, and this is the nature of the belief, across all the benefits that doctors perceive, doctors in India are at least a year or 2 behind because they haven't seen the systems perform the way they are promised. But if you look at them, they're consistent with the approach. So the benefits that the US doctors are seeing from EMR, Indian doctors accept it, willing to go forward, and are actually willing to say so. So my theory on adoption is it's the technology that needs to step up. The doctors are ready. Thank you.
Thank you, Mr. Uday-Kumar, for a very interesting presentation on the EMR adoption. Certainly, EMR adoption can definitely increase when we actually use some of the tools which are very, very, cost saving as well as time saving. Many of the doctors are very busy in the hospitals, and these kind of tools will definitely increase the IT adoption. The next session, I would like to request Mr. Shirish Kulkarni, CEO of PLAS, to go over and present us for the Healthcare Information Exchange.
Hello? Are you able to hear me? Good morning. And there was definitely a view that we heard. I'm going to move around. That's the way that I want to keep it interactive and make sure that I reach out to you, and that is the purpose of this presentation. So I would definitely be moving around and catching your attention if I would like to get it. So I would start with the perspective that is just now been presented is about the doctors, how actually the adoption of the systems that we are going to talk about in IT is impacting because of the adoption of one of the ecosystem member there, who is a doctor or a practitioner. The perspective I'll be bringing in is for actually how the healthcare information exchange as a concept is likely to be looked at from the patient's perspective. Let me give my background to start with. I'm a mechanical engineer, okay? So all of you who are actually the expert in healthcare, I have great honors about your knowledge. But as a patient, whenever I'm sitting and I'm actually performing that, that is something that I said, okay, let's flip and look at, not at the IT services provider, not as a healthcare expert. Let's look at how patient looks at the whole purpose of health exchange, information exchange as such. I was sitting back and thinking about, let us look at what happens in the manufacturing industry. Whether all those dimensions that we look in manufacturing industry, are there any replicas, dimensions that we can draw? We have lean management, where actually wastes actually are coming out of the end-to-end value system is identified. In healthcare system also, there are areas in which you will find out health is actually find out where are the wastes happening. Now, bringing that parallel, I was looking at the concept of health information exchange and fantasizing what it would be for a patient. Just imagine that I'm going into the hospital. There are sensors attached on me. I'm actually getting detected. And the whole persona, the whole history of my record, my family, my preferences, the way that I have been treated at various locations is getting found out. The whole record gets up and I get registered for that particular entry. It could be entry at the hospital. It could be anywhere. If I'm sitting in a car, I'm well connected. My car is connected. And if I'm actually facing any of the severe problems, automatically the medical health would be called. So is that what we are talking about all in theory? Is it all fantasy? And actually, as a patient perspective, I thought myself like this, a poor kid, I'm confused. Here is that, we are fantasizing about digital impact. We're talking about everybody having digital phones. We're talking about adoption of 99%. What is the user adoption? How are we taking care of the patient's perspective? Are we really caring about that? And then I looked at, whenever I enter any hospital, now there is some typical scenarios I'm going to talk, maybe a little bit drastic. Why am I getting asked about certain things and information again and again? Why this question is not answered? Why are there duplicate records? Why am I actually supposed to do same test again and again? If I change one clinic to other clinic, one hospital to other clinic, why is that I'm actually supposed to pay again and again? So why me? Why am I suffering? So this is the way that actually the drastic reality that I brought out, fantasizing about digital impact versus the reality that we are seeing is actually impacting the patients. So can we have something that will actually take care of the patients in the form of the controlled record that we will have? Is that something that healthcare providers will provide me? So my question is, who is going to provide me that particular aspects? Who is going to take care of my own interests and also healthcare providers' interests? Who is going to take care of that? So I started thinking about that. Can I have areas in which healthcare providers identify and create all these records? Can I look at these records being auto-created? Can I make sure that there is a system in which I will have the best patient's experience? Can it be cost effective? Can we look at it basically reducing all the medical errors? Can it reduce cost for me as a patient? Can it generate certain things that I can actually remotely work, just tip of a finger, and I'm able to get all those details at no cost or at zero cost? is it actually one point where I can just look at all those details that are available for my family and the ecosystem, and I share them across? And yes, I looked at it, and Palash has got a solution for that. Palash Fingertips. This is a mobile-based solution that Palash is bringing out. Is basically looking at patients, focus on patients, looking at bringing out Health Vault. It is actually looking at emergency care. It is actually also looking at Medico Helpline, Payer Connect, and API exposure to deal with. So it's a mobility platform that all individuals, like patients, should be able to actually get a handle on their health and their health control. It will also benefit a lot to the healthcare providers. It will have automatic notifications